A new paper published in the UK, Rethinking Statin Dosage in Coronary Disease, advocates for safe prescribing by highlighting that while statin efficacy plateaus at mid-range doses, toxicities increase manyfold. Its lead author is Professor Simon Dimmitt. Welcome, Simon.
Thank you very much.
Let's begin with the fact that your research indicates that while high-dose statins can achieve marginally greater reductions in coronary events, they don't appreciably reduce total mortality compared to mid-range doses. So how should specialists reconcile this with the current guidelines that often push for maximal tolerated doses?
Statins are a wonderful treatment because they directly target cholesterol production, but in all the cells. Cholesterol has its purposes in the function of cells and in the production of hormones. So it was a tension for all prescribers, the notion that statins in clinical trials with the early developed statins, which were milder, improved survival, reduced deaths from coronary disease and total mortality. We haven't seen such positive results perhaps with any other drug class. So the balloon went up. For decades before, it was termed a cholesterol hypothesis. We knew about cholesterol in physiology, but not in saving lives. Lowering cholesterol is a preventive, not specifically a treatment. It has been promoted as an anti-inflammatory, but there are better drugs for that. And as a preventive, to improve survival, you have to have the right patient, the right target, which statins are for the cholesterol production in the cells, and perhaps to be of a sufficient age to be at risk of demise from the damage that cholesterol contributes to in the arteries. So the trials have been enormous in this area and have been very encouraging for the reduction of coronary events and therein hospitalizations, which is an economic question as well. But with respect to survival, none of the higher dose trials showed any mortality benefit that was worth the trouble of the increasing side effects with higher doses.
So how do we make sense of that, especially in light of the fact that most drugs have 10 side effects? Is that playing a part in this disparity between going higher versus staying with the mid-range?
The only drugs that get to market are ones where the benefits outweigh the side effects at the right dose. And the problem for the clinician is everyone's dose is going to be different. So we've been targeting cholesterol levels and ignoring, there is a J-curve in this question, like there is with alcohol and many substances and many drugs, so that you can get benefit to a certain level, a sweet spot dose, which when exceeded gives you only marginal further benefit, but rapidly increasing side effects, which are minimal at the original doses marketed, because the companies have a huge responsibility and are highly regulated, so-called pharma. They have no interest in supporting a drug that is harmful, and they pull such drugs as early in drug development as possible. So by launch, we've usually got pretty good drugs, but you have to find the right patient who has that target on which the drug works sweetly,
yes,
and then follow them up carefully to individualize their dose. We've tried to do that in Australia because we've done a lot of the research on cholesterol, and we have a wonderful hospital, wonderful doctors, prescribers, nurses, and interested patients. So we're very involved in all of this. And the excitement which we all had with the efficacy, because very few drugs have trials that show reductions in mortality and improved survival. But if it's only a preventive, and the patient has no symptoms and they have plaque in their arteries, the GP, who are our main centre stage physicians in this, in coordinating the specialists and the drugs and the pharmacists and the nurses, it's a bit too simplistic to say everyone should be targeting a certain cholesterol level, but below a total cholesterol of about 5, an LDL cholesterol of about 3.5, most of the population studies have shown in people not on statins, and increasingly on statins, that below an LDL of 3.5, mortality starts to go up. So the patient doesn't have symptoms even after their heart attack, and if the statin gives them side effects, they're not interested. And as a consequence, global use of statins has just faded.
Well, yes, I want to pick up on that too, because when you're talking about that level where mortality starts increasing, is this where we think about that, that concept that in some situations, control of a situation rather than eliminating it is a prudent path?
No, exactly. Most of us, when we graduate, nurses, pharmacists and medical practitioners, we're out to stamp out disease, stamp out the pollution, the cockroach, the radiation, whatever it is that we're passionate about. And then, of course, we learn in emergency departments that, as we saw with COVID and septicemia, pneumonia from other causes, that if you don't eliminate a lot of the disease and the cause, people die. But it really is only infections and aggressive malignancy where elimination of disease is often necessary. Even in those conditions, the immune system takes over pretty quickly, including in cancer, most interestingly. So if you control a lot of the disease, the body takes over with the immune system and other restorative measures and recovery. But when you're in the emergency department and people are very sick, you think in acute terms. Taking statins for many years has a cumulative benefit, but if the dose is too high, the side effects accumulate. The least appreciated until recent years was an increase in diabetes from statins, and that has really put the nail into statin prescribing, because a lot of our patients are diabetic or in the future are going to become diabetic. We don't want to make any of their state worse. And so the pullback to the original evidence-based doses for survival is something we want people to consider.
Now, you've previously estimated that the median population oral effective dose, 50%, the ED50, for various statins, I mean, for some of them it sits at, say, 4 milligrams, for example. Given that the smallest manufactured dose is often double or sometimes triple the minimum effective dose, do you think that industry needs to provide lower dose formulations to better support that start low, go slow approach?
The effective dose 50% is analogous to the awful lethal dose 50% we learnt about with radiation in the context of nuclear weaponry and of course safe treatments of a lot of the cancers with very targeted radiation now that we can image disease better. So halfway up the dose response curve, halfway to the maximum effect of the drug, my colleagues say, well, why would you go only halfway? They're spending money, they're taking risks. Why shouldn't they have the full dose? And it's because there's also all these side effects, all of which increase in number and severity with dose. And this has been known for some time. It's just a concentration, mass concentration effect. So trying to get some sweet spot in the middle where the side effects are not noticeable. The problem is if you have no symptoms after your heart attack or your stroke, you will not accept any side effects. You will not take a drug every day for anything where you're not tolerating that drug. And so I mentioned the everyday because the effects of statins take many months to accumulate in terms of the beneficial effects. The trials that showed any acute effect of statins on outcomes in coronary care units were not convincing. The best one had a statistics of P of less than 0.05. You want something much more convincing. So the analysis of all the early trials when less people were on statins was the benefits appeared mostly by the end of the first year. There is no hurry. So a lot of patients realise that it's a business plan that pharma is operating on. Consumers can really find their own best dose as long as they're being supported by their GP, and the specialist is also recommending other drugs for their arteries, like blood pressure drugs, diabetes drugs, and blood thinners. All of those together can prevent people ever going to hospital again, even when they've had bypass or stents. It isn't just statins alone, so they don't need to be increased as if it was the only thing that would save their lives. So I've covered a few concepts in there, but the curiosity was working with pharmacologists in the UK, all the way to Oxford, in fact. The dose response information that the companies have and the pharmacologists and indeed the pharmacists have is quite reliable at drug launch, and we don't need to maximise the dose. In fact, at universities, students are taught to start low and go slow. The benefits of statins take many months to accrue. There is not a hurry, and so it should be with your local physician where you follow through, and if there are any side effects, they're likely to diminish or disappear when you reduce the dose to even taking the standard formulations twice a week, as long as the cholesterol is getting below about 5.5, and the patient has stopped smoking if they do, and is not gaining weight, which we all do if we're not careful in the wonderful places we all live in the countries who I hope are listening to this, and I pray other countries will also have the many advances of technology we have in peaceful times. So I know that there's a lot of concern and distraction about matters like simple prescribing. But there is no hurry, and we have other drugs that also help patients with coronary disease. And we need to stay focused on all of the risk factors, and the most important of the risk factors are blood pressure and clotting. Blood pressure may be up to 10 times as important as cholesterol, according to the biggest studies published in the New England Journal of Medicine and Lancet in the last few years. And so there is advice coming from public health that we shouldn't overdo cholesterol, but if you have had angina, you must be on a statin at some dose because of the benefits shown in the early trials.
Well, that's interesting because global statin uptake remains remarkably low. The figure I saw was less than 3%. So what effect do you think aggressive dosing and the resulting side effects, the new onset diabetes, the myalgia, etc., have contributed to this public hesitancy?
Yes, so it hasn't been studied as well as you might hope, because we've been correctly very dogmatic about everyone should be on a statin if they've had symptoms of heart disease, of their angina. So perhaps we haven't been paying enough attention to adherence and practicality and cost. And my reference to a lot of countries who have where there are other priorities is that if there are drugs, even the malaria drugs and some of the cancer drugs are just not taken because of the toxicity. And the possibility that a smaller dose will do a lot more than nothing in all conditions was something we developed an interest in a long time ago, in the context actually of the mental health drugs, where there is an urgency. People are very ill when they present, and they often do need a higher dose to begin, which is then back titrated or adjusted for that individual patient. And a lot of those drugs should never be stopped, like statins. But you can't take drugs long term without side effects. So we need to be looking for just enough, a sufficient dose. And like a similar interview we did a few years ago, Steve, on aspirin, we learnt that in the context of blood thinners, which have very manifest side effects if you overdo it. So bless the doctors who continue to promote statins, but it only needs to be enough, and it needs to be followed up by the usual physician of the patient consults at their local practice.
Simon, you note in the paper that an adverse event can be at least 5-fold more likely than a survival benefit in some scenarios. What's the best way a patient could ask their doctor, what's my personal number needed to treat for a specific dose?
This is an interesting problem because with vaccination, even at its height, the number for COVID vaccination was 40. A lot of people were having vaccination possibly unnecessarily, but you couldn't pick who needed it. So we've found, I think, a balanced approach of making sure that people who are not able to defend against infection, like children or people with certain chronic diseases, are more carefully targeted. From the point of view of artery disease, lifestyle is the main thing. Not gaining weight, not taking too much salt, and being physically fit and active. So once you're doing all of those things, you may not need too many drugs. And so in some people, blood pressure isn't so important, and in families with high cholesterol, the statins are very important. So it needs very much to be individualized. Just having high cholesterol on its own without other risk factors like diabetes, you will be at a lower risk. So you still don't need the highest doses, but they were made available when we were really doing trials and seeing what was best for people. But the high doses simply seem to be unnecessary in most people.
And of course, without this being construed as medical advice, in closing, I'm just wondering if a patient is experiencing, say, some mild side effects like fatigue or muscle aches on a high dose of one of these drugs, does your research suggest that dropping to a mid-range dose might still provide nearly the same level of protection against a heart attack, for example?
Yes, exactly. The terrifying thing we found when we looked at where this had been tested in a half a dozen very large trials was that even coronary deaths were no lower with the mid-range dose. And in the end, it's survival is king, So, and a lot of people do have angina, which is controlled by other drugs. So, but that needs to be done in collaboration with your physician and pharmacist. But I do encourage patients to read on the internet, with or without AI, and ask questions. And a lot of people are respecting a balanced view with treatments and prescribing. It isn't all or nothing. It's been very sad that apparently many people around the world have taken the all or nothing approach. That there's a loss of trust because the doctor is convinced of the importance of cholesterol, which is always going to be correct, but in some patients it's less, others more important. And so 20 years ago, Britain actually licensed an over-the-counter mid-range dose of statins, which almost led to World War II.5, because of concern about whether the pharmacists were in the right place to take charge of this. But now the patients have taken over from all of us because of the wonderful information available on the internet from reliable sources, which does include some of the hospital clinics, their websites. We have one which talks generally called correctdosing.com, and a book coming soon to help people navigate the website called Dose Matters. And the title of the book is to emphasize that everyone has their own individual dose. So with painkillers, people have seen that. Short term, everyone needs a high dose of antibiotics, but that might be the only situation where everyone gets the maximum dose at the beginning. Usually you should go very carefully in concert with advice.
The paper is titled Rethinking Statin Dosage in Coronary Disease. It's available at correctdosing.com and on the internet. Professor Simon Dimmitt, thank you very much.
Thank you very much.